Good afternoon. Welcome to this session. I hope everyone had a chance to maybe grab a drink, grab a seat, relax a little bit before we dive into this next session. It's really exciting to see the interest of everyone here, especially since this is the prelude to the main conference. The conference hasn't even started yet, but this is a great opportunity to make you familiar with one of the initiatives that are starting in this space. So I'll briefly introduce myself. My name is Nina Steensma. I work with the Clinton Health Access Initiative together with my colleague Pascal Bourquin. And we're hosting this session together with my colleagues Alexander Doxiadis and Emily Weimer from Seek Development, which is a global health strategy consulting firm. So you may be intrigued by the title. So forming a T1D partnership, type 1 diabetes partnership and access strategy. But before we actually dive into the context, I did want to walk you through a couple of practicalities. So we're really keen to make this session as interactive as we can. Obviously, it's a big group, so we really want to ensure that everyone has an opportunity to share their thoughts and input, and especially feedback on what will be presented, what we'll discuss going forward. So in order to do so, and make sure everyone can cast their voice here, is we would like to ask you to log on to Mentimeter through the QR code that you see in the lower left corner of the screen. And the alternative way to log on is at the top, joining at menti.com and using the code that you see right there. The reason that we're doing this is twofold. One is we really want to capture your questions throughout the session and make sure that we get a chance to answer them either throughout the session or afterwards. But if you log on, you'll see a button down there with called Q&A. So feel free throughout the session to enter your questions there, and we'll aim to address them at certain moments in time. The other reason why we would love to ask you to log on is because we will be asking you some specific questions to get your opinion on. And so throughout the presentation, we'll call it out when that will happen. So no need to look at your screen throughout the session, but we'll call it out when we are asking you to provide your input on certain specific questions. So I'll give everyone a chance to log on before I kick off. Yeah. Is everyone set? Lots of thumbs up, which is good. Again, a new way of interacting here. But indeed, I would love to, if everyone's set, we would love to welcome you to this session, which is about forming a type 1 diabetes partnership and access strategy. And to give you a little bit of context, at the highest level, there's been an initial group of funders of initiatives related to type 1 diabetes in low and middle income countries that together with a number of community representatives have really expressed an intent to coordinate and collaborate more closely with the aim of fostering a more coherent and sustainable investments in the type 1 diabetes space, and really to more effectively improve the lives of people living with type 1 diabetes in the most effective way that we can together. And so this group, again, is in a forming phase. It's an early phase, and we're really keen to define priorities for investment, not in isolation, but really by taking guidance and wide input from people living with type 1 diabetes, from LMIC, government representatives, civil society, others who are actively engaged in this space. And so the goal of this session is really to introduce you to a first draft version of a vision, mission, and high-level strategic objectives of this intended partnership, and really gather your feedback and input and perspectives on where this partnership should focus on. So indeed, again, what we'll outline here is not set in stone, and we're really here to get your input and feedback either now or later during the conference. I think in the sessions to come tomorrow and the day after tomorrow, there's going to be a lot more in-depth discussion around some of the topics that will may scratch the surface on today, but really, indeed, we're keen to listen to your thoughts and input on what the most important priorities would be. Now, before I hand over to some introductory remarks from people who represent this initial stage of the partnership, I would love to just clarify that our role as CHAI and SEEK, we're really facilitators for this process. We're not decision makers, so I wanted to call that out explicitly, but indeed, we're really keen to hear your input. So again, if you have thoughts, please come up to us throughout and after and throughout the conference in the coming days. But then, without further ado, I'd love to give the floor to Tino Tenda Tziki to share his initial perspectives on why we think a partnership like this is needed.
Okay, so back in high school, I used to say, I aspire to inspire before I expire. But this initiative, it aspires to join forces, industry partners, just like Nene has already shared, with also some community members, people living with type 1 diabetes, to be co-creators of this thing, what this means to us. So I'm just going to share a bit of some statistics that is already there, on the T1D index, with the current projection that it shows what could happen in the future. It's mostly to say, if nothing changes with the current situation, if you don't change anything, if you don't take action, then we would probably have these. But it doesn't mean that by 2040, we should have the same things. So it's just to inform that if we don't do anything, maybe this could happen, which is staggering, right? So I believe, T1D, for example, the current situation is that type 1 diabetes is increasing rapidly, mostly to do with those in the low to middle income countries, where we know that by 2040, it is projected that maybe 54% of people will be living with type 1 diabetes globally. That is the statistics. If you go and check on the T1D index, I think everybody here is familiar with it because everyone was talking about it. So, and in low-income countries as well, we know that the situation is even worse, where 123% of people, we have 123% of these cases happening in low-income countries, if nothing changes. And by 2040, it is projected also that maybe 9 million people in the low to middle income countries will be living with type 1 diabetes. And maybe to show what has already happened is that the most devastating reality that we have is that we have already lost 6 million people. 6 million people are missing from these conversations. They are missing from life. They are missing because they did not have, or they were denied access to essential diabetes necessities that they needed because they could not afford it or they could not access it wherever they are. So we are here maybe to change this narrative so that we don't get to see these things. And maybe with the current projection, it shows that this is an unacceptable outlook. So that is why we're saying the current projections show that only 8% of people, they've increased in life expectancy to about 37 years. This is not really a win-win situation. In this case, I think it's a failure. So I think we need to do more to make some intervention so that this changes, because we don't want to see this happening. That's why we're saying only all the projections that you see, it says if we don't change anything, this will be the case. And we hope that will not be the case because everyone here is interested in type 1 diabetes. That's why we are gathered here. And so we must act now. That is my call to action, or our call to action. As I represent other people living with type 1 diabetes, our call to action is that we need to improve the early detection, diagnosis, and the access to care. That is what this initiative is all about. And it is important because we, as people living with type 1 diabetes, we are also part of it. And we are trying our best to make sure, okay, can this work? How can this work? What has worked before, and how can we really tweak this to make sure that it is representative? And maybe my last word is that with this, I believe that we have a choice to continue to, on this devastating path, or to commit. I think we need to commit to making some action, because if everyone is doing something differently, I think we just need to come up together and make some collaborations. I think that's the only way we can get this thing to work, to change this said narrative. And with all being said, I'll rest my case. And thank you. This is fun. Okay, so I think I had to say, okay, in this juncture, allow me to call upon Stefan Pearson from Breakthrough T1D to take you further with this. Thank you.
Thank you, Tino. I'm just going to talk from here to save a little time. So as Tino laid out, there are significant challenges that people with type 1 are facing in LMICs. And this group, as core donors in the T1D space, we recognize a pressing need to collectively coordinate our efforts. And so what we have is something called the T1D Access Strategy and Partnership, maybe renamed depending on what we decide. And what this does is aims to bring together significant funders, funding type 1 diabetes access and research in LMICs, and also bring together communities, so people living with type 1. What do we want to accomplish out of this? What everyone in this room wants. We want a world where there is equitable access for people living with type 1. So that is the end goal for all of us that are working on this. We're in the forming stage of this partnership right now, and it involves foundations, industry partners, and of course our community representatives who are very important to this. So we are very keen to engage with a wide range of stakeholders right now, from practitioners to government representatives, communities, and others who may have a voice in this. We want to get your opinions and your inputs to see, are we heading in the right direction? And then just a final note, as Breakthrough T1D, yes, we may be a funder in the space, but we are one voice, and we want to emphasize that we want to do this in partnership with everyone, and that's why we're here today. And I'm going to turn it over to James Reed.
Thank you. Well, thanks everybody. Thanks for joining this session. I must say I'm really excited to be talking about this. Helmsley Charitable Trust is one of these large philanthropic funders of type 1 diabetes. We've been really proud to be working in low and middle income countries for about 10 years now, and have done a lot of work in terms of trying to ensure we really understand the underlying problems driving a lack of access to care in type 1 diabetes. A lot of that has tried to unpack problems like, why is there a lack of access to insulin or test strips? What are ways that we can treat this disease in an integrated model? We've run into a lot of really significant underlying health system challenges within those conversations. And frankly, we've found ourselves presented with a long list of challenges and problems. At this point, I think part of why we're excited about this initiative is really an opportunity for us to move into that diagnostic into action. We recognize that Helmsley alone cannot advance these challenges alone. And at the same time, we recognize that Helmsley, as a philanthropic funder based in New York, it means we don't always have the full picture. We don't always have the same context or experiences as other funders. We may be causing a lack of coordination or problems if we don't work together. And I think most importantly, we recognize that we need to be humble about what our perspective is, that people with lived experience are experts in the disease, but also that governments have their own vision and direction for how to conquer those problems. They're aware, but often need the support to get over that initial hump to get things moving. We know that sort of moving into an action phase means that we don't necessarily know every solution in every context, but by moving together in a shared direction that puts more emphasis on prioritizing activities together, sequencing those activities and making sure we're addressing gaps in an overall strategy, we'll be better positioned to learn and go into greater depth and breadth as we proceed. I think, others on this group have already emphasized the key point here. For me, it's that we're working towards better government ownership and community ownership of these interventions. So we're very eager to get some of those perspectives based on the really diverse group in the room today. And, why we're here and why we're excited about it is something that Tino touched on the first place. I think we see the problems quite clearly. But I think to Tino's point, if nothing changes, nothing changes. And so we need to work together to find out what that something is. So with that, I'm going to pass it over to Bent to hear his perspectives. Thank you.
Thank you very much, James, and of course to Chai and Breakthrough for having started this process. Before I reflect on this from a World Diabetes Foundation perspective, just 2 seconds of reflections from an organizing committee perspective of this meeting. Among the many aspirations we have with the meeting today and in the coming days is to bring together different groups, initiatives, stakeholders, some very new, some which have been going on for a long time, and of course the different constituencies and stakeholders involved. And you've already seen the diversity of the representation here. So that's why we also really appreciate that we have this opportunity to discuss or present and get feedback on a relatively new initiative like this. And that takes me then to the World Diabetes Foundation perspective. We've been working in the space of diabetes care and prevention for 22 years now. And we learned a lot over that time. The best thing we learned and have remained very constant about is that models that should bring support to low and middle income settings should be owned and developed by the countries and stakeholders in these settings. So those times should be over where models are coming from another place and put into a third place. It should be the other way around. So the approach that we are starting out here is exactly in line with that thinking. So it's not even a choice, it's a mandatory approach as we see it. So we appreciate that this is the way the modality is outlined here. And then concretely, we appreciate the fact that the preparatory stage is very thorough. It's very analytical. It's very participatory. And even today, we are requesting a live feedback as we are together here. And I'm sure the entire process that you are handling, Nina and Chai, is exactly with that inspiration. And I think these were my initial remarks. And thank you again for having us here and for being a part of our event today and the side event stream and representing one of the new initiatives that we wanted also to be with here in the program in Copenhagen. And then I think I should hand over to you, Carissa.
Great, thank you so much. So the benefit of going last is everybody's already said everything. But just to echo, at Novo Nordisk, we are participating in this because we really do believe this will be one of these examples where the whole is bigger than the sum of its parts. We've been obviously working in diabetes for a really long time, both through programming, like the Changing Diabetes in Children program, which is its 15th year this year, and aims to reach 100,000 children by 2030. If you take that number and compare it to the type of statistics Tina was speaking to, there's a huge gap still, and we know there is. On the product side, we of course are one of the largest producers of insulin in the world, and we really believe in healthy product markets, and we want to be a part of making them healthier so that access can be more ubiquitous. So on both of those fronts, we really welcome the opportunity to engage and to collaborate. And we see this process kickstarting, very much the forming stage, as folks have mentioned, and the importance of people with lived experience and with government intervention for us is definitely the anchor. I think it would also be remiss not to just, the state of the global health financing landscape is obviously changing very rapidly in front of us. And I think if we look on the opportunistic side, it means that there is room and need for more innovative approaches to answer to the global health needs that are in front of us. So with that, we're at the start of this alongside some great partners and welcome the perspectives to round out what we can achieve together. Thank you.
Thanks so much, everyone, Carissa and Bent and Tino and Stephanie and James. Really helpful. Please you can feel free to like sit down for a while or stay seated here. There will be some questions coming over in a bit, but maybe to indeed like summarize what we're looking at indeed is recapping what Tino just said as well. Like the rationale really for forming a partnership is the very fast-growing burden of type 1 diabetes, especially with the majority presenting in low and middle-income countries, and which in relation to like had limited access to early detection, diagnosis, and adequate care, is reflected, as you see reflected on the right, is really is really expressed in very highly inequitable outcomes for people living with type 1 diabetes, especially in lower middle income countries compared to high income countries, as you see in the chart on the right. Now, that together is really like the rationale for the need to establish a partnership like this. Maybe next slide. And so indeed, as they outlined, there's an initial group of partners, funding partners, who see an important opportunity in order to collaborate more closely to ensure that their investments are more coordinated, really are focused on the most important needs as articulated by governments and communities, and channeled through the most effective and sustainable approaches specifically. And I think the other aim is really to try to activate the broader ecosystem to really increase funding that's channeled to this space as well. And together through that objective as a whole is to, at the end of the day, as you see as a right, like to make a step change in the health outcomes for people living with type 1 diabetes, because indeed, like the current inequity that we see in relative life expectancy, relative type 1 life expectancy is just sheerly unacceptable. So that's the impetus for why we are looking at forming a partnership like this. Maybe I'll hand it over to Alexander.
Thanks, Nina. Hello, everybody. So maybe when we took a step back and actually looked at what was already happening in the space when it comes to sort of initiatives and stakeholders, we looked at both funding and advocacy efforts. And what we saw is that the members of this sort of new to be formed partnership, this what we call the steering committee, already contribute about 40 million a year to type 1 diabetes efforts. And so this was taken from 2019 to 2022 and then averaged per year. On top of that, there's sort of bilateral funding, other philanthropies, contributing another sort of 90 to 130, depending on definitions that you take, also to type 1 diabetes, which sort of then totals up to 130 to 170 million per year. So there's already quite a bit of funding going to that space, but clearly there's then also this sort of opportunity to collaborate and coordinate. And then you see that on the advocacy side, we have found about 16 partners that are really active in this space in about 128 countries. And so you see there's a lot of movement. If we go to the next slide, we actually take a level deeper and looking into sort of what does this sort of funding really go towards. We actually split it into sort of 3 different groups. And so on the left-hand side, that smaller circle is really the funding that goes to specific type 1 diabetes activities. Right? That middle circle is funding that supports type 1 diabetes, but is within sort of the larger context of diabetes. And on the right-hand side, obviously the biggest circle, this is sort of funding that supports type 1 diabetes, but is sort of embedded in that NCD space. Right? And what you see is that we sort of split this up into this gray part and that blue part, where the blue part is really the funding that comes from the steering committee members. Right? And so if you look on that left-hand side where there's obviously the smallest circle, but you can see that the funding that goes to specific type 1 diabetes activities is coming for 45% from sort of the SteerCo members. So it's, there's a reason why we think this sort of partnership can come together and coordinate. Another thing to call out here is that gray part, Carissa already alluded to it, is of course a bit volatile. So this comes from a lot of like bilateral funding, but also includes a lot of like one-off research grants that might not actually continue into the future. And knowing what we know now about the ecosystem and the world is going, we actually really don't know where that gray circle might be in the years to come, making this sort of definitely the left-hand side, the blue part, more important. If Go to the next slide. We also looked into the geographic split. So where are these activities actually taking place and where are the players actually having their activities? And what you can see, this is sort of the world map counting the number of organizations that are active in a country. So both donors, but also sort of advocacy organizations. And what you can see is the picture is pretty diverse. So you see countries where we have a lot of actors having initiatives going on, and we also see countries that clearly are sort of much more on that lower end of the spectrum. So this sort of obviously leads us to, again, this opportunity to coordinate efforts. Could also be an opportunity to say which countries are right now underserved, right? And so there's an opportunity to actually go to other countries as well. And clearly you could also say, let's focus our activities to just certain access determinants and make sure that we actually do that across all countries. Next slide. So just to give you a bit of a super quick snapshot on what that sort of process that we actually are going through look like, we basically split it in two sort of phases, where phase one was really this sort of discovery. I think we lost the slide, but that's fine. We lost sort of, it's a discovery and making that first attempt to write down a strategy phase, which sort of lasts up until March. That's really the phase that we're in, just landing on the first strategic priorities and testing them and playing them back to you and really hoping for the input at this stage. After March, once we've landed on sort of the strategic priorities, we will go and actually go into phase two, which is then really the, how do you operationalize this? What is the operational model around it? What is the governance model that we want this potential partnership then to take place, right? So you're really at that end of this phase one before we really want to finalize, because we really truly will be looking forward to your input right now. So I hand it back to Nina to talk more about where we are now.
Yeah, thanks. I'll share a few words in terms of like where we are in terms of the first draft of a vision and a mission and strategic objectives, to put that out there for your feedback. But I just want to highlight, indeed, like we'll go into Q&A afterwards. So please field any question that you may have through the Q&A button already, so that we can address them in the next session. Again, if you move to the next slide, please. So I want to put out there, like, hey, this is the first thinking in terms of what could be a mission, a vision and a mission for this partnership. And this is where the initial group kind of landed on, but indeed, like certainly not set in stone, but as a vision, they articulated like, hey, like Stephanie said earlier already, indeed a world where all people living with type 1 diabetes have equitable access to type 1 diabetes detection, diagnosis and care in order to be able to live a healthy life. And then the mission is really twofold. One is to partner with governments and communities, as was said earlier, as well, in low and middle income countries to sustainably enhance access to detection, diagnosis and care, including access to insulin and technologies for people living with type 1 diabetes. And secondly, to coordinate and mobilize country and global stakeholders towards priorities that they've been defined by both governments and communities themselves. So I think that's indeed like what Ben, just echoing what you said as well, is the importance of this not being a top-down initiative and setting of priorities, but really be able to listen to like what is most important, that what are the priorities that are coming through from governments, from communities and other stakeholders. So indeed, as you see, there's quite an explicit emphasis on those 2 points. Next slide, please. After this, I'll pause briefly, but indeed, based on an initial review of like existing evidence in the space around access to type 1 care, but also based on discussions that we've had with quite a wide range of stakeholders, over 50 people we've spoken with in a number of countries. I'll tell you a little bit more about that later. But I think like we've tried to synthesize what the 5 biggest priorities that came up through these conversations were, that really where I think there was quite a bit of alignment in terms of like how these jointly cover the most important elements that define sustainable access to type 1 diabetes care. The first is strengthening service delivery to increase equity in access to type 1 diabetes, again, detection, early diagnosis, and comprehensive care, and indeed across different levels of the health system. So strengthening service delivery as a first priority, or first strategic objective. Secondly, more on the supply side, but really to improve access to essential type 1 diabetes medicines and technologies, not just through the existing donation programs, which are incredibly important and life-saving, but also by ensuring that healthy markets are created for the full package of products. So covering diagnostics, insulin, delivery devices, monitoring, the full package of products that people living with type 1 might need. So really that twofold, both, and really including the perspective on we need to ensure that where people are not covered through donation programs, that they're able to access these products in other ways through healthier markets. Thirdly, it's about health systems. And you'll see very intentionally, this cuts across those two other fundamental pillars, acknowledging that these are supportive of these two. But indeed, like supporting the programmatic and financial sustainability of these programs by strengthening health systems, like ensuring better data for decision making, or by ensuring that health services and commodities are covered by health insurance schemes. There are a number of like health systems related efforts that are really critically important to ensure access to care. And then fourthly, and very importantly, also cross-cutting the importance of amplifying and elevating the role of type 1 diabetes communities, and really recognizing the important role that they play in providing peer-to-peer education and support, community education, but also really play a pivotal role in strategic advocacy to governments and in other spaces to emphasize the importance of specific priorities and needs. And then lastly, as we said earlier, is establishing a platform to mobilize and convene additional both public and private sector, private stakeholders, as well as their funding around converging country and community priorities. So I know this is a dense slide and a mouthful, so maybe this is a good time to like pause for questions and comments on these high-level outline of the vision, mission, and strategic objectives. But indeed, feel free to leave your reflections, I think, on the Mentimeter. But I think would love to, be able to field questions also for the broader group of people who are here about this partnership in the first place. There's one first question. Why is the initiative only in select countries? Is there future efforts to expand it? Online watching from Uganda. Anyone keen to take this? I'm happy to, but.
Sure, I can jump in. I think to be clear, the map that maybe you are referencing from Alexander sort of showed where there are currently funded projects, currently active partners. I think that shows basically that there is a real concentration in some countries of some of this funding, and really significant gaps in others. Broadly, I think the scope of this work is trying to encompass all low and middle income countries. And we're trying to think about within that group, how are there differences between different sort of types of countries? We can see that there's kind of trends in the overall capacity to deliver care sustainably based on the income level of those countries, but also the prevalence and incidence of type 1. Leads to different levels of care and government-led ownership of those programs. So how can we kind of diversify and prioritize our interventions by those different country archetypes, if you will? So I hope that answers your question. There isn't really a defined country scope other than low and middle income countries at this time.
Yeah. Next question. Would the inclusion in the partnership of scientific societies with a focus on diabetes be a relevant partner or partners? Teamwork and use of the different competencies? Great question. Ben, do you maybe want to chime in on this question?
No, I think there are two questions. Would the inclusion in the partnership of scientific societies with a focus on diabetes be a relevant partner? And I think it's a clear yes. And I think it was a fine analysis we saw with the mapping and the stratification of international programs and so on. But obviously, there are many other things ongoing in many ways around type 1 diabetes, specifically scientifically, advocacy-wise, and of course the entire panorama of processes around integrated care at different levels. So, meaning that as this process moves along, and actually also responding to the previous question, there will be a country level or context level next stage of analysis. And then it says analysis in a sense, or you can say modality of approach to comprehensive and inclusive and multi-stakeholder. I think that's a word we should have had also in the material, multi-stakeholder ownership. Then it says teamwork and use of the different competencies. Well, as I said, teamwork is another word of multi-stakeholder ownership, and different competencies is the same. So one thing that we've really learned in the past few years, and that we all have to take on as we move along, being it in the bigger NCD space, being at the UN high-level meeting in September, or being here in Copenhagen today and tomorrow and on Thursday, is the multi-stakeholder ownership is the only way forward. There's those days when one agency went there and another agency went over here are over, or they have to be over. And that's also why we should appreciate a comprehensive approach like this with the modalities that I mentioned before around deep country context analysis, models that are built on what is already established and can be refined. And so I think I tried to respond to these two questions. Thank you very much.
Thank you, Ben. Maybe before we go to other questions on the screen, is there anybody in the room that has questions? We have a microphone in the back. Would love to hear if you have any questions, any comments, anything that sort of stood out to you. Yeah, see a hand up there.
Thank you, and I appreciate this partnership and what you're trying to do. I'm Jean-Claude Mbanya from Cameroon. What I notice, and I still notice with what you're doing, is that you are going back to the same areas where there are existing funding. What will you be doing in orphan areas where they don't have funding and they want to be your partners?
It's a great question. Does anybody of the panel feel that? Please.
So I think it's a great question, Jean-Claude. I think, so one sort of finding that we found from some of the submitting our own information around what we're funding and trying to categorize that, first we found that that was really hard to do. Secondly, I think the thing that really jumped out to us is that this funding cohort is really underemphasizing community-based organizations. We know that across the board, from commodity access and advocacy around that, to peer support, to thinking about how they're involved in research. There's really kind of an underinvestment in that area. So I think that is an example of an area where we need to sort of look at specific successes or areas where we are doing well, maybe not at scale, and then think about how we incorporate that into sort of the interventions that we're taking forward. It's part of the package that's been lacking, and probably a critical change maker that we could be re-emphasizing. Maybe there's a lot of focus in a certain country, but we know that there's gaps elsewhere. So how do we address that? That's the type of kind of analysis and change making we're hoping that this mechanism generates. But I will admit we don't have all the answers of how and when and who that exactly means, but yeah, that's kind of my perspective. I welcome thoughts from others, so.
It's exactly like James said. I think that we're starting with strengthening certain areas that we know need to be strengthened, so that when we go to that next phase of looking at countries that don't have those funding mechanisms, we have solid models in place already that we can hit the ground running with.
Sorry, I thought there was more to come. I see another question in the back as well, and then there's a hand up there. But also, I mean, in general, maybe not for now, but if people feel like there are areas that are underserved, that are orphaned, that should be taken into account, please make sure that you talk to one of us, talk to one of the panels, send it through the Q&A, because we definitely do want to learn and move this forward. Just wanted to make that point again. I don't know where the microphone is. Ah, there, sorry, I didn't even see that. Please.
Thank you so much. So my name is Dr. Robert Salamte. I come from Ghana, and it's been great hearing all that you are doing. But I have a question that came up from some work we did in the community, which I haven't been able to answer, and I'm going to throw it back to you. So the community member asked me, I'm hungry, and you want to talk to me about blood pressure. So it's just been ringing in my ears. Everybody gets hungry. And it just kept coming up every time we went into the community. And what really they were saying is, it's not that I'm hungry. It's I'm hungry and I don't know where the next meal is going to come from. So that is something I haven't heard in your strategy. I'm hungry and I don't know where the next meal is going to come from. And I think if you really want to achieve the impact that you want to in the community, then not only at the community level, not only as you engage higher up, because the community will tell you, I'm hungry and I don't know where the next meal is coming from, but maybe also higher up is the same thinking. Thank you so much.
Thank you for sharing that with us. Maybe we have time for one or two more questions.
Thank you. I am Suzanne Sapp from Cameroon. There is another barrier that is called the language. If you want to touch communities, especially in sub-Saharan Africa, make sure that maybe people who are talking French can submit to have funds. Not all of them are able to write a grant in English. So we have French, we have Portuguese, we have Spanish. I know that WDF has a page in French, but for the others, this is a suggestion.
Thank you, that is absolutely well taken. Maybe one more?
Thank you. My name is Ana Mukumbi. I'm from Mozambique. And I really want to say that I'm very happy with what you are describing here. I'm particularly happy with the aspect of detection and diagnosis, because access to therapy and management in low-income settings, sometimes it's impossible if you don't have access to detection and to diagnosis, really investing on it to be sure of what you're doing and how you're doing. So I would like to commend you because you are considering this important. And I think that the second aspect was now said by my colleague that preceded me regarding language. I think that also culture and the way of living and the fact that looking for equity, it's not always easy. If we consider equity equality, we need to be very careful, and we need really to engage the communities from the bottom to understand how people live and why some decisions on management in these countries are taken, mainly in remote areas and in communities where the health literacy regarding these conditions is still low. And I think that health education should be also a priority. Health education that includes co-creation of contents with those communities, because we can learn a lot from the communities too, but there is need to be extremely innovative in education, because I think that it's one step that will help us a lot. Congratulations.
Thank you also for sharing that. And I think community engagement, education, they center quite quite a bit on what Nina's going to talk about more. I know there's a lot of appetite in the room to speak more. I think we probably do want to move on. I wonder if there's any final responses from the panel to what we just heard. If not, then I think we will move on. And please do keep comments, questions, etc. coming, especially online, because then we can actually save them and we can look at them later and we have them. And there's also an opportunity at the very end to get in touch with us through email. So there's a lot of opportunity to keep this going. And so thank you so much. Back over to you.
Thanks, Alexander. If you guys want, you can feel free to like sit back and relax, but thank you. Can you? Yeah. Can you move to the next slide? We went through this. Yeah. Oh, yeah. Do we want to go to the breakout question? Yeah, okay. Yeah, I think one of the key questions that we wanted to get your reactions on through Mentimeter is indeed like across the strategic objectives that we just put in front of you, those 5 big pillars, like what role should this partnership play? Like any initial thoughts that you have would be really great to hear your voice on like what role should this partnership play across those 5 objectives. There should be a pop-up on your Mentimeter screen right now to voice any initial thoughts. Okay, this is great. A lot of ideas are coming up. I definitely see indeed like the importance of coordination amongst funders, but also facilitating connections across, I'm assuming, across multiple like stakeholders and implementing partners, mobilizing more funders for the space, particularly some of the non-traditional NCD funders, government, indeed, like empowering and education of governments. I'm assuming, indeed, education of governments on the importance and the significance of the type 1 burden and the need to address this intently. Advocacy for government prioritization and investment. Behavioral interventions beyond drugs and diagnosis. Is there anyone who'd like to just clarify this point on behavioral interventions briefly? Indeed, perhaps otherwise, indeed, showing enhanced commitment, keeping local context in mind, which hopefully will also attract additional stakeholders to join. Press on the issue of pricing, and then it disappears behind another button. Transferring manufacture of diagnostics to Africa in proximity to the burdens. This is really helpful. I definitely see. Oh, yeah. Oh, wow. Much more, indeed. Thank you. Integrate and strengthen diabetes care in the existing health system for local acceptability and sustainability. So really institutionalizing it more strongly within the health system. I think that's definitely something we heard back from other conversations earlier as well. Bringing up the voices of people living with type 1 is reflected in the importance of elevating communities as part of a strategy. Improving self-management, I think, incredibly important element of comprehensive care. Definitely, we hear that loud and clear. Engage stakeholders, communities, investments from governments to step up. Empowering advocacy. this is really helpful and very, very rich input. I won't go through all of this, but what I do see, and indeed keen for others' perspectives, but I do see a lot of topics that are indeed like find a home in one of those 5 objectives, I think, and indeed like it really matters in terms of how do we flesh out those strategic objectives and translating them into specific interventions and activities that address the points that you're bringing up here in further detail. Capacity building for peer-to-peer education. I think indeed the importance of what I see from like at first glance, indeed emphasizing the importance of governments in providing sustainable type 1 diabetes services and care, emphasizing the importance of the role of communities, indeed, and the importance of like coordinating across stakeholders. So this is really helpful. Thank you so much for your input and ideas here, and definitely something we'll take on board as we're in the process of like translating and trying to focus in terms of what does this really mean, as James said earlier, how do we translate these points into like concrete priority actions that should be implemented. Thank you so much. This is great. Perhaps to move on, because we have about 40 minutes left, and there is still some quite a few further details that we would love to share and get your input and feedback on. So we have talked about these 5 objectives, but we also really realize that there are differences and quite substantial differences in how these 5 objectives may manifest like across different country contexts. So I think we really also, like through the conversations that we've had, really acknowledged that there really is a need to tailor objectives to different country needs. So as you see on the left, we have the 5 core strategic objectives, but like what we try to do to tailor them to country needs is to try to start defining like 3 country archetypes, really based on the level of diagnosis, health outcomes, level of government ownership, income levels. And we sought input from a range of stakeholders across these 5 countries to really better understand like what are now the specific needs and priorities in each of these contexts. And one thing I would love to emphasize is like, we didn't define those country archetypes to be static or like classify countries in a static way in each of those 3 archetypes. So there is certainly not intended to force fit any country into these categories, but it was really intended to acknowledge the need and to facilitate a discussion on how specific needs and priorities may differ across different contexts, and of course, eventually also on an individual country by country basis. I just want to put that up front. This is not intended to force fit, but really to facilitate those discussions that priorities will differ. But to give you a very high level impression, indeed, like the 3 archetypes as we defined it are, and I just will run you briefly through this, but indeed, starting off all the way on the left with what we call country archetype 1. These are countries with particularly low access to diagnosis, as reflected in the diagnosis rates that we see from the T1D index, but also from the ward study, that translate also into high rates of DKA, upon diagnosis, very high missing prevalence rate, and low relative T1D life expectancy. And these are often perhaps countries that are more dependent on external partners and donors for the provision of type 1 diabetes care and commodities. Now that going to country archetype 2, those are countries where diagnosis rates show to be better. Yet still access to type 1 diabetes services are suboptimal, as reflected in like a still high missing prevalence and low relative type 1 diabetes life expectancy. But we do see that governments are taking increasing ownership of the provision of type 1 diabetes service provision and procurement of medicines and technologies. So there's a bigger role that governments are stepping up into in those country contexts. And then country archetype 3 are countries where we do see significantly higher diagnosis rates, as well as like health outcomes, including better access to insulin and monitoring. And indeed, like governments here account for a substantial share of the provision of type 1 diabetes services and access to medicines and and diagnostics. As said, like we have been trying to better understand priorities, as you'll see in the following slide, in each of those country archetypes by doing what we call deep dives in a number of countries. We've spoken with stakeholders in Burkina Faso, in Ethiopia for country archetype 1, then in Ghana and Cambodia, and in India in Madhya Pradesh for country archetype 2, and in Kerala for country archetype 3. Again, please don't pin down on like where these countries per archetype fit, but indeed, like we've definitely tried to get a wide picture in terms of how does this reflect, how do differences reflect by country archetype. And we're indeed like currently engaging with additional stakeholders in other countries and are reflecting back with those who we engaged with in those 5 countries to really, validate kind of like the synthesis as you will see it right here. And indeed, like I think this is also particularly an area where we're keen for your input in terms of like what are specific priorities by country archetype. Maybe indeed, like I just wanted to show you on how some of the key indicators are reflected if you look at them from country archetype to country archetype. When you look, starting with incidence, definitely the highest burden in terms of absolute numbers of people, with incidence of type 1 diabetes is in country archetype 3, but the growth rate is definitely highest expected to be highest in country archetype 1. And indeed, like it's just stunning to see like incidence is expected to almost triple in the next 15 years. Just maybe pausing a bit to reflect, but that's incredible growth, like and not in a positive way, but in country archetype 1. And indeed, if you see that, like how that translates into like diagnosis rates, those are understandably lowest, as I said, like in country archetype 1. But these are also the countries that present the highest percentage of onset cases presenting with DKA. Country archetype 3 definitely, as you see, has higher diagnosis rates and substantially fewer cases diagnosed in DKA. And then, indeed, I think these access gaps translate into substantial inequity in relative life expectancy, and the gap between background life expectancy and type 1 is highest in country archetype 1. But I think we can all agree, like this gap is still very much unacceptable across each of the 3 archetypes. So hence, really forming a clear impotence to do more, not just in country archetype 1, but across country archetypes. So indeed, like coming back to the question earlier, not upfront focusing on single countries or single archetypes. I think that's really a discussion that we would need to have, but I think it's a clear case and calling out the need across. Maybe next slide. Okay, I know this is a very dense slide, so please bear with me on this, but like, what we wanted to do is kind of like share with you, like what have stakeholders who we spoke with, what have they said, and how does this differ from country archetype to country archetype across each of the 5 strategic objective areas as we defined. So I'll just run you through what you're actually seeing on the slide in abstract before we dive into content first, but indeed, this captures stakeholders' perspectives by country archetypes, across, and you see the little icons on the left, which represent indeed like strengthening service delivery, improving access to insulin and technologies, strengthening health systems is the third one that like a mechanic circle, strengthening the role of communities and improving stakeholder coordination all on the bottom. So indeed, this tries to capture the differences that we've been hearing. Perhaps to start with what we have heard, and the most important thing is like the big blue arrow that you see on the top. And I think this was an area where I think there was a lot of like consensus around the need to, the priority to work towards a long-term objective of sustainable government-led provision of type 1 diagnosis and care related services. So that long-term desire of like, hey, this should be government owned, and it should be, and that's also what ensures sustainability throughout. I think that was definitely clear consensus that we've heard across all of the stakeholders that we spoke with. Then there are two other kind of like cross-cutting objectives, or like areas that we heard that weren't distinct when you look at country archetype by country archetype. And those are the ones in orange. And the first one is really the need to enhance availability and affordability of insulin and technologies by improving market health for essential products, for these essential products. So to ensure that those who are not covered by donation programs also have access to affordable, available commodities, whether they purchase in the private sector or whether they're procured through governments. And then secondly, indeed, like the second orange arrow is indeed to the need to identify and mobilize existing and new funders around a set of converging priorities and really setting direction for broader T1D funding and advocacy. So cross-cutting objectives. Then if we go country archetype by country archetype, you see the blue boxes on the top. And again, this is hard to nuance, but I do want to make an attempt to reflect what we've heard, and indeed also particularly an area where I think your input would be beneficial. But indeed, like what we've heard in country archetype 1 was really the importance of ensuring that the survival of people living with type 1 by ensuring that basic essential type 1 care infrastructure and diagnosis is in place, and by ensuring that people really have access to the most essential type 1 diabetes medicines and technologies. So ensuring that we really reduce missing prevalence, that we really ensure that the people who are currently missing are found. Then secondly, in country archetype 2, what we've heard was indeed like an increasing call for supporting governments to take an increased role in provision of core T1D services and access to medicines and technologies, while still indeed focusing on better diagnosis and ensuring that no one is missed. We saw that the diagnosis rates are better, but certainly not optimal in country archetype 2 as well. And country archetype 3, voices that we heard was really indeed the importance of solidifying sustainable government ownership and also working towards elevating the level of care where this is feasible. So those were just to characterize what was highlighted as the biggest priorities based on what we've been hearing from country level stakeholders and others. Now, I won't go into the details for each of the three, but we did want to focus on and get your input specifically on country archetype 1, and if we have time, perhaps even in country archetype 2, is indeed really to see is where this is what we've heard in terms of priorities that have been articulated in each of those strategic objective areas, the 5 that we discussed earlier. But indeed, getting your perspective is, are these the right ones? Are these the right priorities? Are there priorities missing? Are there indeed areas that are orphaned that we may not, one of our colleagues here mentioned earlier, are there things that we have a blind spot for that should be elevated here and that aren't? So I think that's what we are really keen to hear from you. I think perhaps I'll just walk through this for country archetype 1 in terms of what we have heard and play that back, but indeed, this is the second area where you see where we will ask you to go on Mentimeter and cast your input and voices. But indeed, what we heard for as priorities in the area of service delivery in countries in archetype 1 is indeed ensuring that basic type 1 care infrastructure is in place with increasing geographic spread. So, but also, for example, ensuring that there's adoption of national T1D guidelines and really ensuring that MD capability to provide treatment is in place, and in parallel to ensure that there's that it's feasible to find more people living with type 1 earlier by enhancing healthcare worker capacity to recognize signs and symptoms earlier and to refer rapidly. So really also going down to lower levels of the healthcare and build capacity of healthcare workers to at least recognize early signs and symptoms and ensure that children and adults who are displaying these can be referred rapidly. I think when we look at the the category of when we speak about like access to essential commodities. The key thing that we've heard for country archetype 1 is indeed the importance of sustaining and where even possible, like expanding the donation programs, because they have such an incredible life-saving impact. They're vital in saving lives. And I think the other thing that was mentioned is like the need to work increasingly jointly with governments to ensure that the right conditions are in place, that people who graduate from these donation programs at some point in time are able to access continued care through government-provided services and procurement of commodities. So strengthening that connection around graduation into a continuum of strengthening the continuum of care into adulthood. Now, indeed, for strengthening health services, strengthening health systems, I think there was definitely acknowledgement to support governments to initiate and take initial steps to, for example, really start laying foundation of like building essential health systems building blocks, like for example, starting discussions and taking those initial steps, for example, to establishing a diabetes registry or to ensure that there's a budget line for diabetes commodities in the health budget. But taking those initial steps and moving from there, acknowledging that some of these processes are just like lengthy and time consuming and will probably evolve across the multiple country archetype levels. And then lastly, around communities, what we've heard mostly is indeed the importance of really identifying and activating community networks where they often aren't or don't exist or don't have the resources to strengthen, but really ensuring also like early integration of these community networks into the health system, acknowledging their important role in providing additional support to people living with type 1 diabetes. Maybe let me pause here and move to the questions. I think so. In the QR code, when you see the Mentimeter pop up on your screen, it starts with one question, correct? Which is indeed like, are any strategic priorities for country archetype 1 missing? Up to 3, please provide your thoughts like via the comment functions, but indeed, like we're really keen to hear, are there other things that are really standing out to you that are not captured in context that you recognize yourself, like, or like that you acknowledge are country archetype 1? Again, like, I don't want to put it set in stone, like country archetype by country archetype, but like in those contexts where you feel like, what is most important? Is there anything missing? I mean, perhaps if I may start, two things that I'm picking up here is indeed indeed, thank you again for your input. This is really, really rich and very helpful to think about this. One thing that I picked up on indeed is the calling out health education. That's I think I see come back a number of times, and the importance of it, but also empowering programs for self-management of type 1 diabetes care for patients and making it sustainable. The other thing that I saw, and I think actually on which we had quite a bit of discussion, so really keen to hear broader group perspectives. So if you did write this down, I think it would be great if you could stand up and perhaps share a little bit more, is indeed the point around decentralization, to consider that across all country archetypes. And this was a point I think we had indeed, as I said, quite a bit of back and forth on. And indeed, the way it was framed currently, it's going to be it's going to be important to have access to adequate care in the first place before further decentralizing it more broadly, but at least to have certain points where people can access care and initiate treatment that is effective and of high quality before expanding that capacity to lower levels of the health system. But indeed, I would love to hear for someone who made this point. I think there was a similar point that was made up there a little bit more broadly to, share your perspective earlier on this. Or anyone else who has perspectives that he or she wants to share on this. Maybe we can get the mic going around.
So I lost the connection to the Mentimeter. So I just wanted to add one point, which isn't mentioned as far as I can see, and that is comorbidities and primary health care. We at WHO, we just published TB diabetes guidelines, and in many of these CA1 countries, the only real primary health care similarity is TB clinics or family planning clinics. So that's an important thing to start where there is an opportunity to add on a component. Thank you.
Thank you. No, that's a great point. There's
Yes, I'm Dr. Texo from the Philippines. My comment is regarding the strategic priorities. We will find out what is missing unless we will. I agree with the protocols and guidelines, but unless we will implement it and evaluate it, and we will find out what is missing, so we could do corrections from there.
other thoughts or things that are missing here? I would love additional perspectives. Yeah, acknowledging that government ownership work should take place in country archetype 1 as well, early taking up of the responsibility. So I think definitely fully agreed on that note. Anyone else? Others, Alexander, Pascal, things that you would like to call out, or others that have perhaps any reactions from the group of people who were just up there in terms of any surprises that they're seeing? think this last one is also an interesting comment. Bridging the gap between the health systems and other systems across all of the country archetype. Did you make that? Yeah, we'd love to hear your...
I think the type 1 diabetes. My name is Crispin from Rwanda. I think type 1 diabetes care is more of a family disease than individual disease. So the access to care depends on, from the other perspective of the patient, how big is the distance to go to the hospital? Is there any discrimination involved? So all of these, empowering the patient in the development of, economical development or career development, it helps the patients to better access to care. So we are now into bridging one side of the bridge, so the healthcare, and the other side, the patient. So it's important to look at the other perspective as well, so to make sure that we meet together.
Yeah. Thank you. No, that's valuable perspective. Thank you. Any other thoughts? I think the one thing I would love to say still, indeed, like I see a lot of comments in terms of like, hey, why are certain things not covered in archetype 1 and like, hey, are covered in archetype 2 and 3. Definitely hear you on those points, and I think indeed like that's been a discussion that we've been having. And I think one thing that I just want to emphasize is like here we're not seeing it as either or, but indeed like initiate some of these processes in archetype 1, and as countries like would move on, like I think just going back to that overall arrow, acknowledging that some of the efforts and interventions will take time, and like some of them may not be realistic to like implement full-fledged in country archetype 2, but in country archetype 1, but like take initial fundamental steps at that point in time. And I think getting your guidance in terms of which are appropriate, which are feasible in that context, to build out over time into to build those out over time in the years to follow. All right, thank you so much. Okay, then now this is another question I think where we'd love some reflection on. If you go back to your Mentimeter, like we wanted to get a like very high level sense of priority from you in the discussion that we have here. So if you go to Mentimeter, you'll see that you'll get 100 points. And we would love you to allocate these across the 7 points that are here that reflect like the 5 priorities plus the cross-cutting priorities that are articulated in the slide that you've seen. But it would be really helpful to get a steer from you in terms of where is most support needed, and where, like in terms of where do you see this partnership specifically add the most value by assigning those points across the 7 points as you see reflected in your Mentimeter. And indeed, really with the perspective, like keeping in the mind, in the back of your mind, like where do you feel this partnership specifically would add the most value? this is interesting. A lot of like swifting priorities over time, but. Still movement. All right. Okay, one more. Sorry. Okay, I see that 43 people have casted their votes. So, any final opinions? Then we start. I'm just worried, like it's going to flip at the last minute. But I do think, and this is really interesting to see, I think there is very strong emphasis on improving healthy markets, which is a cross-cutting objective. And I think that's really interesting to see as an outcome and a clear priority to improve access to essential type 1 medicines, so insulin and technologies, and to enhance affordability for governments and people living with type 1. So that's a very clear, priority, I think, and this has been quite stable up top for a while now. I think the second one that is, I hope this will stay in place as well, but I think indeed is the importance of essential having strong type 1 diabetes care infrastructure in place with increasing geographic spread, including the adoption of national guidelines and expanding capabilities with MDs. So I think that like has service delivery bucket as a priority is definitely finding a lot of consensus, I feel. And then there's, I think, a shared, 14, 13, 13. But maybe I think that this has been a close tie for a while. But indeed, like strengthening diagnosis, finding more people living with type 1 earlier by enhancing healthcare worker capacity to recognize signs and symptoms and to refer rapidly. I think like strengthening the diagnostic capacity coming up as a clear priority. And then glad to see indeed like the importance of identifying and activating community networks and ensuring early integration into the health systems as another like fourth priority, tied with the need at the global level to identify and mobilize existing or new funders around converging priorities. So indeed, like the last few are relatively close, but definitely this is incredibly helpful to see and interesting to see such a strong emphasis on those first two, I think, being called out as a very strong necessity. Thank you. This is really helpful. I'm wondering, perhaps just to ask a few opinions from the room, did people fill this out clearly with type 1 with country archetype 1 in mind, or more broadly? Broadly, yeah, that's what I would assume. So thank you for doing so, because I think that will help inform us, because we are like running close to time. Again, it's really this is very helpful to see, and a clear call for action. Sorry. Yeah, I want to maybe then wrap up this and maybe open the floor in the last 5 minutes to. Sorry, I'm deaf. There were some more questions that came through throughout the session from people in the room online. So I'm going to call out a few and perhaps also ask James, Stephanie, Tino, Carissa, Bent to see if you want to address some of these initial questions as well. But the first question, would the steering committee consider including government representatives to ensure that the interventions are built from bottom up? James or Bent, perhaps? James, do you want to? Yeah, or is there, I think there should be a mic here.
Thank you. Yeah, I mean, I would respond to this question and sort of say the steering committee is just like a thinking group in some ways to sort of think about what are ways that we can work better together. In order to action any of these interventions or really be like practically investing in things, I think the group is very much aligned that those investments need to be absolutely inclusive and driven by government representatives. I think from my perspective, I'm hesitant to approach a government, a busy, non-communicable disease government official without a rough draft to respond to, a vision or an idea. So I think the goal of this is to kind of have an idea, a direction, priority interventions that we can take on. But as we're even sort of looking at ranking those country archetypes really broadly across country archetype 1 in 10 different categories, it's very abstract and far away from reality. And so that discussion would need to happen in a given country with the leaders about what their specific needs are in order to move the agenda forward. So I would say this is a very, very early stage, and that's, you know, ideally what I would expect, like Ben said, is an absolute requirement for this work to move forward. So yes is the answer. I would also add that a lot of the information that Nina has shared has come from, you know, 40 plus interviews in each country that's been conducted by this group. So not the steering committee ourselves, but representatives of that group to engage governments, but also key civil society organizations that are engaged there. So they're not coming out of thin air, but coming from that type of engagement, being respectful of their time as best we can.
Then there's a question around, like, regarding strategic priorities in Pillar 4 around community, what is meant by institutionalizing the role of community networks? Please be careful here. Good point. I think, I'm happy to take a first step, but indeed, please, Renze, Stephanie, add to what I'll say here. I think it's really meant to make sure that, like, more widely in the health system, and like the important role of communities as stepping up in like provision of peer-to-peer support and education is incredibly important. Acknowledging the role that they play. Yes, Renze, feel free to.
Hi, everybody. I'm Renze Shibilia from Breakthrough T1D, very much involved in community efforts, also very much involved in the Language Matters movement. And who knew, words matter. I think perhaps, I agree, institutionalising is a term that I think there would be a number of community members who would prickle at that, perhaps. And I think it could be very simply reframed to be something like involving or incorporating. It is not a matter of saying that community networks must become institutionalised and fall into line and be under the purview or control of institutions. It's more about ensuring that there is that true involvement, that co-design, co-development, real focus of lived experience, which has been the basis of this work. And we would like to see that then continue through all that's done there once it's implemented. But words do matter, so that's a really, really useful pickup. So
great point. Yeah, thanks, Renze. Yes, there's another question here. Comments here from the room. Over here.
Hi, Catherine Karekezi, NCD Alliance of Kenya. Just to support what has just been said, I think it's more a matter of meaningful involvement of persons with lived experience, ensuring that whatever is developed is actually patient and person-centered. Thank you.
Thank you. Really important. Then there was an open question, will this partnership consult in country? Yes, definitely. We have indeed, like as you saw, like we've been speaking with stakeholders, government stakeholders, medical practitioners, community representatives across these initial 5 countries. We're looking to expand that and cast a wider, but indeed, like I think that's especially also where a big part of the people who are here being practitioners in country, we would love to hear from you and hear your inputs and feedback in terms that should be, things that should be changed, things that should be altered in terms of level of priority that you feel are not well represented here. So yes. Any other questions? Otherwise, I think like I'm standing between you and coffee break. I do, and I would love to then maybe wrap this up right now to give everyone a breather and a chance to like get a short break. I do want to bring up one final thing as first of all, really thank you for all of your input. This has been really rich. And again, like we're capturing this offline and we'll be looking at your comments and try to reflect and make adjustments in what has been put on paper so far. So again, thank you for your very extensive input. Much, much appreciated. I realize we only covered one part of the discussion around country archetype, archetype 1. And I think indeed we are looking for wider input. As Alexander mentioned earlier, we are still in that strategy development phase. Again, this is not set in stone, and we are like wanted to like put out like an initial version to you and get feedback and steer from all of you. So I think one important thing that we do want to do is an offline consultation process. So if you look on the last Mentimeter input, we are asking you if you would be willing to take a look at the initial like draft document that articulates like vision, mission, strategic priorities, and indeed like a breakdown of priority and more to some extent like also a little bit more concretely specific actions that have been called out by stakeholders across countries in each of those archetypes. So it goes one level deeper than what we've been covering here. But if you would be willing or interested in providing additional offline feedback on a draft overview of strategic priorities for this partnership, we really would love your input. So please, indeed, like it would be great if you can leave your contact details through the pop-up in Mentimeter, and we can share with you a draft document for your offline input, either end of this week, early next. But indeed, really grateful for wide input. So, and again, like I'll be here for the coming days. Please catch me with additional comments and thoughts. But I want to say a very big thank you to all of you for your input, and also to Bent and WDF for the opportunity to present this initial intended partnership to you here and have an opportunity to capture your perspectives on whether we are working into the right direction. But thank you very much. This was very, very helpful. Much appreciated.